Hello everyone, I hope you are as excited as I am because as always, I am excited because this is video number 2 in our discussion on the respiratory system. And in this video, we are going to start talking about the physiology. And you know me, I get all tingly inside when I get to talk about physiology. So I'm all sorts of excited. Ha, I'm sure you're making a face at me, but that's okay. All right. So let's just pick up where we left off. In the first video, we spent a lot of time just going through the anatomy. So after we talked about the functions of the respiratory system, we spent time going down the respiratory tract and talking about the structure and the function. We ended here on the bronchioles, which is where we're going to pick up, and then we'll talk about the alveoli. However, as I like to do, I like to just do a little review because the more times we go through it, the better. So remember, we have the upper respiratory tract, the nose, pharynx, and larynx, and then we have the lower respiratory tract, the trachea, bronchi, and bronchioles. We went through things in order, and as you are studying, you should be able to eventually be able to go through this order on your own. So it would sound something like nose, nasal cavity, nasopharynx, oropharynx, laryngopharynx, larynx, trachea, primary bronchi, secondary bronchi, tertiary bronchi, bronchioles, terminal bronchioles, respiratory bronchioles, alveoli. Good. You are going to get there, my friends. So we ended off talking about the bronchioles. And what was unique about the bronchioles, they're microscopic, but what was unique about them is that they are surrounded by smooth muscle. And this means that they have the ability to constrict and dilate. And right here, these are the bronchioles, right here, where we do a lot of either constriction or dilation as a way to regulate airflow. And you remember from our discussion of the blood vessel chapter, we can constrict and dilate blood vessels. So we're going to see when we get later in this chapter to our regulation of the respiratory system, one of the primary ways to regulate airflow is through constriction and dilation of the bronchioles. If we want to bring more air into the alveoli for gas exchange, then we'll dilate the bronchioles. If we don't need as much air to come in for air exchange, let's say we're at rest, we're sleeping, then we can constrict the bronchioles a bit. Okay, I got a little out of breath. I got so excited. So these bronchioles lead into the terminal bronchiole area in the pink, and then the respiratory bronchioles areas in the green. And this is our first area where we have a respiratory zone. Remember, we could also describe the respiratory tract in terms of function. And we said that the conducting zone are areas where the primary function is just to conduct air. And of course, along the way, we warm, filter, and humidify it. But it is in the respiratory zones that we can actually carry out gas exchange. And the respiratory bronchioles and the alveoli is where we can do gas exchange. Let's jump into the alveoli. Okay, I do have some pictures here of the histology. You do not need to know any of these, but I do want to point out this picture right here actually shows you a cross-section of the lungs. And you can see all of these are alveoli. So you see we have such a high surface area. We're looking at the bigger cross-sections of the bronchioles, a cross-section of the blood vessel. So there's a bunch of stuff, but I just want to point out the majority of our lung surface area is made up of these alveoli, which means just a ton of surface area, which means an ability to do a lot of gas exchange. Okay. So speaking of the alveoli are these bundles. They form bundles because we can increase surface area. People say they resemble a grape bundle. Technically, we could call each individual little round part an alveolar sac. I'm not that worried about it. Let's just talk about the whole bundle as the alveoli. And of course, this is going to be a site of gas exchange. I'd like to point your attention to the fact that surrounding each alveoli are capillaries. Because as we talked about, we're going to have to do gas exchange. Gases are going to leave the inside of the alveoli. For example, oxygen will diffuse out of the alveoli into the blood vessels. There has to be something for those gases to diffuse into. And at the same time, CO2 will diffuse from the venous blood back into the alveoli so we can bring it back up through the respiratory tract in reverse and breathe it out to get rid of it. Don't worry about these things yet. We're going to talk about that later. I do want to remind you that lining the alveoli is a very thin lining made up of simple squamous epithelial tissue. That's a good thing because it's thin, which means it allows for exchange through it. We also have lymphatics in the area. We have lymphatics everywhere. Just a little reminder. And look at the total number of alveoli we have. It's just insane. Suffice to say, we have a lot. Millions of alveoli, which just means we can do a lot of gas exchange. Excuse me again for blowing my nose. I'm sorry. Okay, so not only do we need to talk about the tissue that lines the alveolar membrane, which as we know is simple squamous epithelial tissue, there's also some specialized cells that line the alveoli. We have type 1 or squamous cells, and we have type 2 or great cells. You need to know these. Make them your friends. They're really important. So our type 1 cells, let's see. Our type 1 cells are these little purple dudes. There's one there. There's one here. You can see this one is labeled as a squamous or a type 1 cell. There's one over here. So these cells are squamous, which means that, as you can see, they're pretty flat. They are thin and broad, and these are the cells through which we will do a lot of gas exchange. So what we're going to find later is that a lot of this gas exchange is happening through the type 1 cells. And then CO2 will move in this direction. So type 1 cells. You can see down below the gas exchange is happening, if not through the cell, right near it, right? So squamous type 1, thin, broad, they allow for gas exchange. I'm not going to ask you this number. But then we also have these great alveolar cells, and as the name tells us, they're big, these purple doohickeys. The importance of the type 2 alveolar cell is that it secretes surfactant. I mean, this could not be more important. Could not be more important. These type 2 cells, these type 2 alveolar cells, secrete surfactant. Surfactant gives a little moisture. So if you look at this picture, do you see this little blue film? What we have is a little layer of fluid. And that fluid is surfactant. I think the textbook talks about that fluid as kind of being like dishwasher detergent, or like what you wash your dishes with. So it's a little bit slippery and kind of soapy. So we need this surfactant for a lot of reasons. So one of the reasons we need this surfactant is to keep the surface tension low, which I'm going to discuss in a minute. And another reason that I'm going to add, and because I'm writing it down, this means you need to know it, right? Another reason why this surfactant is important is because gases diffuse into water first, then diffuse across the membrane. So when we talk about gas exchange in a little bit, we'll talk about how they diffuse. Gases will diffuse from high to low concentration through a semi-permeable, thin, simple squamous epithelial tissue. But another key to that is we're going to see that the gases dissolve in water first and then diffuse out. There's a law for that. We'll talk about it later. So that surfactant is needed because we're going to need it for gas exchange. But another reason, and this can be a little tricky, but I'm trying to make it as clear as possible. We need some surface tension. Surface tension, the best example of surface tension is, imagine a summer day. It's warm, not like it is now. As you can see, I'm recording in February. Ew. Excuse me. Excuse me. I don't like winter so much. It's having a negative effect on my body. Coughing. Joke. Imagine a warm summer day and you have a pint of your favorite beverage. Maybe it's lemonade. Maybe it's Yingling Lager from Pennsylvania, America's oldest brewery. I went to college there, so I became familiar with it long ago. But if you have a drink and you have that glass sitting on a table and it's warm, there'll be some condensation. So the condensation on the outside of the glass will drip down to the bottom of the glass, and there'll be some surface tension generated between the bottom of the glass and the table, which means that it'll be a little bit sticky. So if you want to pull that glass off the table, because that water is there, you're going to have to pull a little bit harder because some surface tension has been generated. So here it's no different. We have some fluid here because we need some surface tension. And we need some surface tension because it keeps the alveoli inflated. So that pressure that's generated, like the pressure between the bottom of the glass and the table, that pressure that is generated in this case helps to keep the alveoli open and expanded and inflated. If we didn't have that surface tension, the alveoli would be prone to just deflating. And even when we're not filling that alveoli with air, when we're exhaling, we're not bringing in air at that moment, we don't want the alveoli to flatten every time we exhale. So part of the job of the surfactant is to maintain some surface tension, enough to keep the alveoli inflated. But the way the surfactant is made, its composition, the amount that we have, which is not that much, keeps that surface tension low. So we need some surface tension to keep the alveoli inflated, but we have to keep it low. And the fact that, as I said, the surfactant is kind of soapy, like your dishwasher detergent, it keeps the surface tension low. Okay. Excellent. We also have some macrophages in the area, which are some white blood cells, which is perfect. We have air coming in from the outside, so we want to have some white blood cells right there to help us. But I'm not going to ask you that. Just know the type 1 and type 2. Pretty cool, huh? Here's some information on surfactant and premies. I'm not going to ask you this on a test, but it is really interesting. This is one of the reasons why it's been so difficult for scientists, researchers, and doctors to be able to keep premature babies alive at a certain week. So I think, what are we at now? If I'm going to say 20 weeks is like the magic number. So even though it's still really tense at that point, we have the science, I believe, to actually have a shot at keeping the preemie alive if they're 20 weeks or more. And of course, it's always advancing. But one of the big problems in that advancement is that premature babies only start to produce surfactant around 26 weeks, and they don't really make enough to be functional until 37 weeks. So that's one primary reason why preemies that are premature enough haven't been able to function outside the body, because they don't have enough surfactant. Now, in the NICU, we can actually deliver some surfactant to help them, which is pretty cool. But again, not on the test. Okay, make sure you review the route of airflow into the lungs, which I have already gone over. A couple words on the lungs. We've talked about the structures in the lungs, but let's talk about the actual lung tissue itself. We have 2 lungs, you know that. Please note that the right lung has 1, 2, 3 lobes, and the left lung only has 1, 2. The reason the left lung has fewer lobes is because the heart is situated a little bit to the left. It's a really bad heart. So the heart being a little bit to the left takes up some of the lung tissue. That's all I want to say so far on this screen. Everything else is extra. You know me, I'm prone to throw out some interesting cross sections. Well, here is a transverse cross section taken mid-thorax. And again, I just like to give you some perspective. So you can see here, it's taken mid-thorax, okay? And we can just get a sense of relationship of organs to each other. We can clearly see the heart. Okay, because this is the front and the back, this is going to be the person's right side. This is going to be the person's left side. All right. Look at the aorta, by the way. The aorta is absolutely huge. And it's well protected between the heart, lung, and the vertebrae, or the bony vertebrae and the spinal cord. If you ever get the chance to do a cadaver dissection, you're interested, please do it. One of the things, I've done it 3 times in my educational career and teaching career. One of the things that I was most surprised by when I did it was the size of the aorta. It's like a garden hose, because that's how much blood we're pumping out per minute. But look at this, it's huge. Also, in this picture, you get a good perspective of the way that the lungs surround the heart. It's lovely. We can see that, look at the anterior. There's not really that much between the front of the body and the heart. I mean, a little bit of skin, the sternum, and then the heart, right? Last thing I want to point out, notice the pleural cavity, which we're going to discuss next. The lungs sit in this cavity, and that cavity is needed because the lungs, they're going to expand when we fill our alveoli with air, and the lungs themselves are going to recoil a bit. They're not going to flatten, but they're going to recoil a bit when we exhale. So having this cavity is important to give space for the lungs to fill with air and then recoil a bit. Excuse me. Okay, so we call the covering of the lungs the pleura. Pleura, covering of the lungs. And I know this isn't the most advanced picture, but it's really the best picture I've been able to find. I mean, they're identified here, visceral pleura, parietal pleura, but I just think it's a little bit hard at first, so sometimes a simple drawing is simple and best. The pleura, collectively, is the outer covering of the lungs. Okay, so what's between these brackets? So it goes all the way around, right? The outer covering of the lungs has 2 components. We have an inner lining, excuse me. We have an inner lining called the visceral pleura that I'm going to put in blue. So we have an inner lining called the visceral pleura. Visceral means deep. And then we have, let's make it green, huh? And then we have an outer covering called the parietal pleura. Parietal means outer. So the whole covering is called the pleura, but we can separate it into two layers. There's an inner layer called the visceral pleura, and that inner layer clings directly to the lungs. And then we have an outer layer called the parietal pleura that clings to the chest cavity. And of course, in between, we have the pleural cavity. That's the black space we saw right here. So in between is a space called the pleural space or pleural cavity. And I've already introduced to you the function of that. The pleural cavity is there to, let me add one here, allows room for lungs to expand. Because I said, as we inhale air, the lungs will fill a bit. So we need some space. So the pleural cavity gives us space for the lungs to expand. There's a little bit of fluid in there, which reduces friction. And we're also going to create a negative pressure gradient, which I'm going to talk about in a moment. So just jot that down for now, but we're going to talk about it in a moment. So inner lining, parietal pleura, visceral pleura, outer lining, parietal pleura, space in between, pleural cavity. Functions of that pleural cavity allow space for lungs to expand when we inhale, reduces friction because it's got a little fluid in there, and it allows for a negative pressure gradient, which we will talk about in a moment. Excellent. This will not be on the test. Sometimes you can have either air or blood enter the pleural cavity, and the lung will deflate. Look at this x-ray. It's pretty bad. This lung is normal, but here we've punctured that pleural cavity and the lung will deflate like a balloon that you poke a hole in. That can be really dangerous because now we can't use one lung. So if in fact you have fluid in that space here, you can put a needle in there to drain the fluid and allow space for the lung to fill up again. But this is not going to be on the test. Please don't be putting a needle into your friend's side. Let's not do at-home thoracocentesis. All right. Okay, I think that's pretty much all the anatomy. I told you this chapter can be a little tricky. Now we get to the physiology. I talked about this at the beginning of the lecture. So the last thing I want to do for this video, because we're going to have a third video, because there's so much to talk about. The last thing I'm going to do in this video is just go through ventilation and the negative pressure gradient, which actually I thought we were going to have, but let me go back. You'll have to forgive me. I said I was going to talk about it, and I didn't yet. So let's talk about this negative pressure gradient, because we're going to need to know about it when we talk about ventilation or breathing. Now, at least I'm prepared here. So I'm just going to draw a lung. Let me look at the picture again, because every time I draw a lung, people say it looks like a testicle. And I'm sorry about that. Okay. That's not so bad. So let's talk about this negative pressure gradient that develops between the covering of the lungs called the pleura. Okay, so let's just establish the anatomy. We have two coverings of the lungs. The outer covering, which I'll leave here in black, is the parietal pleura. And then we have an inner covering that clings directly to the lungs called the visceral pleura. And then there's a pleural cavity in the middle. Okay, so we're going to introduce pressures, because what we're going to find out when we talk about breathing or ventilation is a difference in pressure. And our unit for pressure is going to be millimeters of mercury. Okay, so let me talk about this negative pressure gradient. Let's give an example. So let's say, what color can I use? Let's use blue. Let's say that our intrapulmonary pressure is 760 millimeters of mercury. This is inside the lungs, so it is called intra means within, our intrapulmonary pressure. So we're going to compare pressures here, okay? So we're going to talk about the intrapulmonary, and that's inside the lungs. But we're also going to talk about the intrapleural pressure. So now we're going to talk about the intra, or within the pleura cavity, the intrapleural pressure. That's what we're talking about here, right? Intrapleural pressure. Well, whatever the intrapulmonary pressure is, in this case it's 760 millimeters of mercury, the intrapleural pressure has to be less. So let's say if the intrapulmonary pressure is 760 millimeters of mercury, then the intrapleural pressure is going to be 756 millimeters of mercury. So that in itself, folks, is the principle of the negative pressure gradient is. Whatever the intrapulmonary pressure is, the intrapleural pressure must be less than intrapulmonary. So there is a negative pressure gradient, which in itself isn't that descriptive. So that's why I want to give you an example. Whatever the intrapulmonary pressure is, the intrapleural pressure must be less. At rest, it's usually 4 millimeters of mercury less. That's why I chose these numbers. So I said and this is an example of at rest, when we're not necessarily breathing hard or exercising or stressed. If our intrapulmonary pressure, the pressure of all the air filling the lungs, is 760 millimeters of mercury, then our intrapleural pressure is probably going to be 756 millimeters of mercury. 4 millimeters of mercury less. The reason this is important is because, let me go back to black. As Amy Winehouse once said, keeps lungs inflated. We need the intrapulmonary pressure to be greater, because if there's an instance when the intrapleural pressure is greater, then the intrapulmonary lung would be squeezed and it would deflate. So imagine that the intrapulmonary space is blown up like a balloon. And there's all sorts of examples online. Go to YouTube and you can look at a video about negative pressure gradient, and they'll use a 2-liter soda bottle or a balloon. The idea is the intrapulmonary pressure is filled with more air like a balloon. So imagine if we fill this with air, like you're blowing up a balloon. The only way to keep that balloon inflated is if the pressure inside of it is greater than the pressure outside of it. That's the only way to keep a balloon inflated. We blow up that balloon with air, and the air is contained so that the pressure increases. A balloon can only stay inflated if the pressure inside the balloon of air is greater than the pressure outside the balloon. If the pressure gets equalized, or if the pressure outside is greater, it's like poking a hole into the balloon, and air will rush into it and it will deflate. So we never, ever, ever, no matter if we're just hanging out on the couch, no matter if we're exercising, no matter what, we always, always, always have to have a greater intrapulmonary pressure. And we always have to have a slightly lower intrapleural pressure. That relationship, where the intrapleural pressure is always lower than the intrapulmonary pressure, is called the negative pressure gradient. Good stuff, right? Really important that you go through that. Okay, so to end this second video, let's talk about ventilation. Ventilation is just a fancy word for breathing. When you ventilate, you breathe. And breathing is one complete cycle, or one ventilation is one inhalation and one exhalation. You can say inhalation or inspiration. You can say exhalation or expiration. Either one. This is the first step of how the respiratory system works. We need to get air in, get oxygen in, do it when we inhale, and then push CO2 out when we exhale. Let's talk about it. Now, you could always probably tell. I have the worst poker face or the worst poker voice. We talked about the relationship between pressure and volume in the heart chapter, didn't we? Well, the same principles that govern blood flow also govern airflow. And in some ways, it makes our life a little easier, but we still have to go through it here. So now we're giving a name to this law. Boyle's law just states that there's an inverse relationship between volume and pressure. When lung volume is high, pressure is low. If lung volume is low, pressure is high. What we're going to find out is our ability to ventilate is all about altering these pressures. And when we develop a pressure gradient, air can flow from one place to another. But we are going to go through that. Of course we are. All right, so you should know this, Boyle's law. Boyle's law just states that when pressure is high, volume is low. When pressure is low, volume is high. Okay, we are going to go through it. And I'm sorry, these little boxes, my little arrows don't show up when I bring it over to my iPad here. Let me add the arrows, and we're going to make sense of it later. So we have the information in words. We have the information kind of in a picture. And then we have a summary. Let me just fill this out. We increase volume, which lowers pressure. Okay, when we relax, we decrease the volume, which increases the pressure. So you'll have the information. By the way, that's summary of pulmonary ventilation. But I'm going to open up another thing here. Save that. I want to open up a new one. Okay. So let's first talk about inhalation. All right, I'm going to draw another lung. Let's do, trying to see if oh, that's really bad. See, I've already started to make a bad lung. It's like I need to go back and look at it it's so stupid. You can see it's good that I'm not an art teacher. All right, so we have, there's a lung. Okay, And then I'm going to draw another one over here because we're going to talk about exhalation, and it's really bad. All right, so let's talk about inhalation. So what happens during inhalation? We are going to, when we inhale, just think about it. If I ask you to inhale, you feel that your lungs get bigger, right? So when we inhale, our lungs get bigger. When we exhale, our lungs get smaller. Excuse me. I got something down the wrong tube. So in order to inhale, we are going to increase lung volume. So again, we're going to be going off of the relationship between pressure and volume, just like we did when we talked about the cardiac cycle and blood moving from one chamber of the heart to the next. So when we inhale, we're going to increase lung volume. And we can refer to that as, let me go over here, thoracic volume. It's the same thing as lung volume, really. You can use different words. Thoracic volume or lung volume, either one. How do we increase lung volume? Well, it just doesn't happen on its own. So the way that we increase lung volume is by contracting the diaphragm and our external intercostals. Excuse me. So the way that we increase lung volume is by contracting some of our respiratory muscles. Here we go. We're going to look at this side first. We will contract the external intercostals and the diaphragm. Let's talk about these both. The diaphragm. You recall the diaphragm. It's kind of shaped like a little hood here, right? This is what separates the thoracic cavity from the abdominopelvic cavity. When the diaphragm contracts, it pushes down. So imagine at rest, the diaphragm is up. When the diaphragm contracts, it pushes down. And when it pushes down, it increases our lung volume. The external intercostals, these are attached to our ribs. When the external intercostals contract, they pull the ribs up. So here we have the external intercostals pulling the ribs up, and we have the diaphragm pushing down. When those happen together, we're doing two different things that both increase our lung volume. Have a look. Our diaphragm is responsible for about 2/3 of the increase in lung volume. So our diaphragm really has the most to do with it, but we still rely also on our external intercostals. So we will contract our external intercostals to pull the rib cage up, and we will contract the diaphragm to push this down. And what that does is it increases our lung volume. Okay, so for inhalation, we increase lung volume by contracting the external intercostals and the diaphragm. Diaphragm pushes down. External intercostals pull the rib cage up. And we know that because of Boyle's law, when volume is increased, what happens to pressure? It goes down. So we have a decrease in intrapulmonary pressure. So we increase the volume, which decreases the pressure. Perfect. And by the way, I'm talking about intrapulmonary pressure. The intrapleural pressure will also be decreased. Okay? But I'm just going to, for the most part, talk about intrapulmonary because we already just understand that whatever the intrapulmonary pressure is doing, the intrapleural pressure does also. But the intrapleural pressure will still remain less than the intrapulmonary pressure. So here we have now developed a pressure gradient. And the pressure gradient is between the atmosphere and the intrapulmonary space. So now we have lowered pressure inside the lungs so that the pressure in the lungs is lower compared to the atmospheric pressure. So all we have to do is contract our respiratory muscles to increase lung volume and increase lung volume enough to drop the lung pressure below atmospheric pressure. Let's throw some numbers at you. Atmospheric pressure at sea level is 760 millimeters of mercury. Albany proper is like a couple 100 feet above sea level, so we're pretty close to sea level. Now, if you're in the hills of Rensselaer County, you're a little bit higher. But just for a starting point. So if our atmospheric pressure is 760 millimeters of mercury, all we have to do is increase the volume enough to drop the pressure to 759 millimeters of mercury. That's it. Because that is enough. And this is breathing at rest. I'm not talking about exercise. That is enough to develop a pressure gradient. And if we have high pressure here and low pressure here, air is going to move from high to low pressure. That's how we inhale, folks. We contract our respiratory muscles to increase lung volume. By increasing lung volume, we decrease the lung pressure. Once the pressure in the lungs drops below pressure in the atmosphere, we've developed a pressure gradient, and if we open our mouth, air will move from higher pressure in the atmosphere to lower pressure inside of our lungs. You don't have to suck in the air at rest. I mean, you can. That's just developing more of a pressure gradient. But your respiratory muscles will do the work for you. And because you developed a pressure gradient, air will naturally move from high to low pressure. This information is all right here. So we inhale, we contract the respiratory muscles to increase lung or thoracic volume, which decreases the intrapleural intrapulmonary pressure. Anytime the intrapulmonary pressure is less than atmospheric pressure, air is going to flow in. Here are some numbers. Did I say 760? Yeah, I did. You don't have to know these numbers. You don't. I'm just making a point. Quiet means at rest. I'm assuming you're at rest right now, unless you're on the treadmill listening to this lecture. So if we're at sea level, where the atmospheric pressure at sea level is 760, all we have to do during inhalation at rest is get the intrapulmonary pressure to be 759. That's it. So our body's really efficient. We don't need to contract our respiratory muscles more and waste energy. And whatever our intrapulmonary pressure is, the intrapleural pressure is less than that. So if our intrapulmonary pressure when we inhale at rest is 759 millimeters of mercury, then our intrapleural pressure will be 753 millimeters of mercury. Now, what if we are exercising and we need to bring in more air? Well, we can do forced It's kind of hard to see, isn't it? Let's change the color for you. We can do a forced inhalation. And all you have to do with forced inhalation is contract more respiratory muscles. So now instead of contracting only these two for rest, forceful inhalation, now I'm going to also contract the pec minor. So I'm just contracting additional musculature to increase the volume even more. And if I increase the volume even more, it will drop the pressure even more. And the greater the pressure gradient, the more air will come in. So you can see, by the way, there's many muscles that we can contract during forced inhalation. Please just be able to give me one example. So one example is the pec minor, which also pulls the rib cage up. Oh, excuse me. But when we do forced inhalation, we increase the volume of the lungs more, which reduces the pressure more. So at rest, we may only reduce the intrapulmonary pressure 1 below sea level, below the atmosphere. When I'm forcefully inhaling, I'm going to reduce the pressure in my lungs to a greater degree, which develops a bigger concentration gradient, pressure gradient, more air comes in. Excellent. Now, let's talk about exhalation. Exhalation is what we consider to be passive at rest. And all that means is, all that has to happen is the diaphragm relaxes. So let's come back here, and now we're going to talk about exhalation. All we have to do with exhalation is, well, obviously if we increase lung volume during inhalation, we're going to decrease lung volume during exhalation. You know this, when you breathe out, your lung cavity gets smaller. We're pushing air out. It's like you know that tool that you use in a fire, the bellows, is it? Where you push it together and it pushes air into the fire? We're exhaling, we're lowering the volume. Well, how do we lower the volume? Relax diaphragm. All we have to do is relax the diaphragm. And when we relax the diaphragm, it will lower the lung volume. And guess what? When lung volume is low, so we have decreased lung volume. Because of Boyle's law, when lung volume is low, the pressure is high. So we've just done the opposite. So now, if we have that same atmospheric pressure of 760 millimeters of mercury, all we have to do is increase the pressure 1 above that. So now we have a pressure gradient where the pressure is higher inside the lungs and lower in the atmosphere. So air will move from higher pressure in the lungs to lower pressure in the atmosphere. Cool, right? So it's considered to be passive at rest. That diaphragm contracts so forcefully, because remember, it's responsible for 2/3 of our movement to inhale, that the diaphragm relaxing itself is enough to lower lung volume, to increase the lung pressure, so it's greater than the atmospheric pressure. And then the same thing. What if I want to do forced exhalation? I'm just going to contract additional muscles. so I can lower the lung volume even more. I'd like you to know just one example. And be careful because we had the external intercostals, which contracted during inhalation at rest. But here, we have the internal intercostals that will contract during forceful exhalation. So when we want to do, actually, I should have put this down a little bit more so it can be consistent. So we said increases intrapulmonary pressure. Well, this was at rest, but what if I'm exercising and I need to forcefully exhale? Well, for forceful exhalation, I'll just contract the internal intercostal, because the internal intercostal pulls the rib cage down. The external intercostal pulled the rib cage up to increase lung volume. The internal intercostal pushes the rib cage down, which will lower lung volume even more, which would increase our pressure even more. And if we increase our pressure even more, we develop a greater pressure gradient with which we can force more air out. Again, we can look at some of the numbers here. Quiet exhalation means exhalation at rest. All we have to do is lower the lung volume to increase the intrapulmonary pressure so it's 1 greater than sea level. But when we do forced exhalation, we lower the lung volume even more, which increases the lung pressure even more, so we can push out more air. And as always, whatever our intrapulmonary pressure is, our intrapleural pressure is less. You can see that when we have forceful breathing, the difference between the two gets even greater. But no matter what, the intrapleural pressure always has to be less. Are you loving the physiology? Oh my goodness. Okay. So I just want to finish. Oh dear. Okay. So much to cover. So much good stuff, huh? Well, let me finish this topic. I think it'll be important to finish this topic. Okay. Before we go on, there's one more thing I want to talk about, and that is what happens when we are, let me open up a new one. We'll save that. What happens if we are at a high elevation, right? So normally during inhalation, if we're at sea level, so we're not at high elevation, the atmospheric pressure at sea level is 760 millimeters of mercury. So during inhalation, we have to contract respiratory muscles to increase our lung volume, which decreases the pressure. So let me use black, I think you can see it better. During inhalation, we contract respiratory muscles to increase the lung volume, which decreases the pressure. And at sea level, we only have to drop the pressure inside the lungs to 759. But what happens when we're at altitude? Let's say you're on top of a mountain. You're in Denver. How about I can't spell? You're in Mexico City. Altitude. Well, what happens to the atmospheric pressure when we are at higher elevations? It goes down. So let's just say at Denver, and I don't know these numbers for sure, but I'm just giving you an example. Let's say at altitude, the atmospheric pressure is 740 millimeters of mercury. So now, contracting the respiratory muscles like I just did to bring the intrapulmonary pressure to 759, that is not enough to bring air in. So at altitude, I should say high altitude, at altitude, you have to contract more respiratory muscles and more forcefully. So the normal effort that is usually enough to bring in air at sea level is no longer enough. So you have to work harder just to bring in the same amount of air. So now I've got to contract more muscles and I got to contract with more force because I need to increase the volume even more to decrease the pressure even more. Because at altitude, I've got to get this down to 739. So this, my friends, is why it's harder to breathe at a higher elevation. Because the atmospheric pressure is lower, so your respiratory muscles have to work harder. They've got to work harder to increase the lung volume, to decrease the pressure, to develop a pressure gradient. You don't need to know these numbers, but the idea, okay, that at a higher altitude it's harder to breathe because you have to contract your respiratory muscles more to increase lung volume more in order to reduce the pressure more. Because the normal pressure that you might bring it down to is no longer enough. Excuse me again. All right, good stuff. I'm just going to pause for 1 second and turn on a light here so I can finish this video more clearly. All right, because we are not done with our fun. No, no, no. Okay, a couple of end things to end this chapter. I want to make a point here. The composition of the atmospheric air is always the same. So it doesn't matter what altitude you're at. And that's why these are included in parentheses, percentages. No matter what altitude you're at, the atmospheric air is about 21% oxygen. I'm going to get my calculator up because I want to run some numbers for you. So I'd like you to have an idea of these numbers. I would never give you a multiple choice question where it's like, what percentage of the atmosphere is oxygen? 20.7, 20.8, or 20.9? That would be ridiculous. Instead, just have an idea. So I think it's easiest just to round it up to 21%. So no matter what the atmospheric pressure is, 21% of that atmospheric pressure is oxygen. Only about 0.04% is carbon dioxide, and most of it is actually nitrogen, which is pretty interesting, right? I mean, I think so. So let's just run through some numbers. Again, I'm not going to ask you these, but now, okay, before I do that, make sure we talked about Boyle's law. We're going to get through some laws here. So just make sure you remember these. Boyle's law tells us that there's an inverse relationship between pressure and volume. When one is high, the other is low. Now we're introducing a second law, called Dalton's law. Dalton's law tells us that the total atmospheric pressure is the sum of all the pressures of each gas. So here I'm going to give you some numbers just to start to go through this with you. So we said that this would be the pressure at sea level. All right, so let's do sea level. Sea level, the total pressure is 760 millimeters of mercury. How is that going to break down? Well, we would just do the math. 21% of 760 is 159. Oh, let me fix that there. Of that 760, 159 of it is oxygen. Which 78.6? 0.786 times 760. 597 of that is nitrogen. And then we would do 0004. I gotta think for a minute. You're making me think, darn it. Somewhere about 0.3 is CO2. Did I do that right? 597 plus 159 equals, oh, it should be not, see, I did the math wrong. About 3 or 4 of that is carbon dioxide. So the percentages stay the same, right? Because oxygen is about 21%, nitrogen is about 78.6%, carbon dioxide is about 0.04%. Because what if I give you an example now in Denver? Now the total atmospheric pressure might be 740 millimeters of mercury. Well, how would that break down in Denver? Well, now I would just take 21% of 740. So now it'd be 155 of oxygen. So the amount of oxygen is less, but it is the same percentage overall. We just have a lower overall pressure. And then we would do this times 740. So we'd have about 581. So there's less nitrogen in the air, but it's still 78.6% of the whole thing. So I'm not going to ask you these numbers. Now we'd have about 4 of CO2. So it's less. Oh, wait a minute. Apparently I can't do math very well. It'd still be about 3 because it's such a small percentage. My point is the actual amount of pressure from each of oxygen, carbon dioxide, nitrogen might be less, but it's still the same percentage. So the composition of air never changes in percentage terms. The amount of oxygen will go down, but it's always going to be the same percentage of our total atmospheric pressure. Okay, you don't need to know these bottom numbers, so don't worry about that, but I want you to have an idea about these, okay? All right. I want to just mention something. Oh, excuse me. So make sure that you familiarize yourself with partial pressure. When we talk about gases in the respiratory system, we're going to be talking about each gas has a certain partial pressure. So when we talk about, in our next video, we're going to talk about PO2, or we'll talk about PCO2. What we're referring to is the partial pressure of oxygen, or the partial pressure of CO2. And partial pressure is just the pressure that that gas exerts against its environment. So if we were going to go back to these examples down below, the partial pressure of oxygen in the air at sea level is about 160 millimeters of mercury. It's considered a partial pressure because it's not the whole atmospheric pressure. Oxygen is only part of it. When we talk about the body, we're going to talk about the partial pressure of oxygen in the lungs. The partial pressure of oxygen in the lungs is about 100. Which means to say that of all the pressure from all the gases in the lungs, the amount of pressure coming from oxygen is 100. So it really isn't a big deal, but when you see that P it's a partial pressure of that gas. And it's considered a partial pressure because it's part of the whole. And by the way, I mentioned this, but I didn't actually talk about it. Dalton's law is just what tells us about the total atmospheric pressure. So if I said at sea level the total atmospheric pressure is 760 millimeters of mercury, well, that total atmospheric pressure is the sum of all the partial pressures of the individual gases. So Dalton's law tells us that the total atmospheric pressure is equal to the sum of all the individual partial pressures. Okay, I'm getting a little carried away here. I did the same thing already with that. You don't need to know about this. We talk about carbon dioxide that we exhale. Carbon monoxide is so dangerous because it will bind much, much, much more to hemoglobin. So if you are ever exposed to carbon monoxide, it's dangerous because once it gets into your body, the carbon monoxide will literally kick oxygen off of the hemoglobin. And then you're not going to be able to transport as much oxygen. But this is just extra. You don't need to know it. Smoking is bad. Don't do it. Okay. I'm going to pick up with this in our next video because I've been talking for quite a while. So we will pick up with this in our next video. Keep up with your studying. Ask if you have questions. Come to an office hour or schedule one with me because I want you to do well. All right, folks. See you next time.